Hey, it's Dr. Bill with just the tip of urology school. And today we're going to do a session with one of our new nurse practitioners who's just beginning her training in urology school, and she's done quite well. We're going to introduce Michelle. Michelle, thanks for joining us for taping. I appreciate your help. Um, we know we've been talking about a lot of stuff in clinic, and we've been seeing a number of patients with prostatitis. Prostatitis is certainly something that comes across our clinic on a daily basis. Even in primary care, we will see patients with prostatitis. So I'd like to talk about some basic guidelines on and how to assess these patients and appropriately treat them and decide, when it's out of our realm of comfort, maybe we should get the urologist involved. As always, we're going to be just giving just the tip of issues with prostatitis, and we encourage our students to look at the American Urologic Association websites. There are apps like Up to Date, which are excellent. A lot of medical journals, both primary care and urology, will have their own take on prostatitis. So what can you tell us about prostatitis and what you've seen in the clinic so far?
Hi, Dr. Bill. Thanks for having me on your show. I am very happy to be here. I have seen, actually, I think the most recent case was probably over the phone. We did some telehealth, and there was a gentleman who had persistent symptoms. It wasn't an acute episode, I wouldn't say, because he didn't have any fever or chills, but prolonged symptoms of issues with voiding and painful symptoms to the abdomen or to his bladder, as he would describe.
And I don't recall that exact patient, but did that patient also have some uh, difficulty or concerns with sexual functioning, any pain or testicular pain or ejaculatory discomfort?
It wasn't on his priority list. He did have some testicular discomfort. The dysfunction
Oftentimes
set.
that constellation can include sexual health issues as
Yes.
well. So, how did you go about assessing and figuring out the differential diagnosis and figuring out how you'd want to treat this patient initially?
So initially, I think we just did a in-depth history and physical with him. We went, down to the basics of what is your urination like? How often are you getting up? Are you having any leakage concerns? Is the urine foul smelling? Is it cloudy? Is it clear? Are you able to feel like you're emptying your bladder completely? And then we move on to other questions such as where is the pain? Because a lot of the patients do present with pain to their low abdomen, to their testes, penile pain, pain with ejaculation, and any pain down there basically is what these patients present with. They can even radiate, as you told me, to their low back. So all things to take into consideration when we see these patients. And I think that actually in the past, this patient had been on antibiotics before. And so we were going to try that again.
And so, if that, and this was on telehealth, so it was a lot of empirical assessment and treatment. But what if that same profile, that same case study, presented in our clinic for a physical exam? What kind of things would you be doing?
If it was a physical exam and he was here, well, first I would want to rule out the acute prostatitis. So I would ask about fever, chills, and any symptoms systemically, of course. And then I would go ahead and move forward with a physical assessment. So your general physical assessment, including, one of his testicles, and if it was not acute, then I would pursue a digital rectal exam to assess the prostate.
Why do you let me for illustrating purposes? Why do you make that distinction between acute and chronic, and whether you would proceed with a DRE?
So with an acute prostatitis patient, we don't want to assess the prostate because we can then cause sepsis, and this can be very dangerous for the patient.
So, and that's great, Michelle. That's perfect. So the bullet point on that is that be aware of the chronicity. If the patient's sick, you really don't want to stimulate the prostate. If you're really not sure, gently touch the prostate for whether it's boggy or soft or tender. You don't want to do a vigorous massage that we would, or a vigorous evaluation that we would normally do to assess for abnormalities like nodularity. We're not concerned at this point about a cancer. We're concerned about what the prostate feels like, and if it's tender and soft and boggy, you can appreciate, and if the patient and the patient elicits a lot of discomfort, or expresses a lot of discomfort during the exam, that will give us some great clues. Your point, don't spend a lot of time massaging and get the specifics of the exam. It's almost like you're saying prostate present, and that's all you want to know, and see if
Yeah.
it's tender. So that's a very good point. Um, Talk to me about your analyses and post-void residuals, those kinds of things.
Yeah, so here at the clinic, we always have our patients leave us a urine sample, and with the symptoms, we would obviously want to order a UA and culture if indicated. We can obviously see the UA and then make that decision when the patient is here. And then a post-void residual. So if the patient did leave a urine sample, we would want to make sure that he was empty to mostly empty his bladder with an acceptable PVR if there is one. If not, it leads us to, again, along the thought process of some inflammation going on with the prostate.
So PVR post-void residual, how much urine is left after after the patient tries to empty the bladder. So you have an assessment of prostatitis. You've got a healthy guy without any allergies. What would the treatments be at this point?
So we can do a few things. We can take into consideration any allergies like you mentioned, and then we could help if he is having some obstruction like symptoms with some medications to help ease the urine flow, like Flomax or Proscar. And then we would also initiate antibiotic therapy, and we would go with either the Cipro 500 milligrams BID, and that's always going to be an extended therapy. And if not, we would also potentially prescribe Bactrim. And again, extended therapy. So low and slow is what I think I learned.
So you illustrate a couple of very important things when you're dealing with prostatitis. The last one being is that we're using um, antibiotic therapy for much greater than 3 days, 7 days a week, or even 2 to 3 weeks, sometimes up to 5, 6 weeks. And the reason is, and I think you pointed out, that when we look at prostate tissue, the bacteria are hiding in little cavities within the prostate. Think of a sponge, and you're cutting that sponge in half, and you have a lot of little areas where bacteria can hide. The prostate is a structure that has a lot of glands, a lot of cavities in it in which bacteria can hide. And if that fluid is infected, it takes a long time for antibiotics to get there, and there's a lot of real estate for that bacteria to hide in. So we use prolonged treatments. You also mentioned the use of the two medications, Flomax and Proscar, and those um, illustrate two different classes of drugs. One is an alpha blocker, and
Yes.
an alpha blocker is utilized a lot in our practice. And what are we achieving with alpha blockers?
Alpha blockers help to relax is it the urethra? You're gonna have to correct me now.
Oh, right. Well, I don't have to correct you. I'm going to, with your permission. So the prostatic capsule and the bladder neck is relaxed. Alpha receptors in those areas are rich, so we use alpha blockers to relax those receptors. And what the alpha receptors do is tighten up the prostate. We want to relax them with alpha blockers, so it allows for the capsule, prostate tissue, and bladder neck to relax. It improves flow. So one of the etiologies to prostatitis is that there's inefficiencies in the way we're urinating. And so if the prostate is tender and inflamed, we can relax that a little bit with the use of alpha blockers. The other medication you mentioned, Proscar, or 5-alpha reductase inhibitors. That's a totally different class of drugs. We use that sparingly,
Okay.
and that doesn't relax. It actually shrinks prostate tissue.
Mhm.
What else can you tell me about that medication, that class of medications?
The 5-alpha reductase inhibitors.
I can see a sweat. That's good. So now I know there's a little more, there's more of a role for me here. So those classes of medications take anywhere from 3 months to 6 months to
Oh,
help
okay.
actually shrink the gland. So that's not what we're looking for. There is a
Monitoring.
little bit of reduction in swelling that occurs pretty quickly. And if you're having some inflammation, infection where there's actually bleeding or hematospermia, blood in the semen, we can actually temporarily shrink um, the prostate glands and the prostatic vessels. So there's some long-term and short-term benefits for both classes of drugs. The 5-alpha reductase inhibitors have some potential side effects with gynecomastia and erectile dysfunction, as well as new data that indicates that there may be some negative impact on sugar control. So we want to think pretty carefully about deciding whether we want to use those. So that's great. I mean, those classes of medications certainly have a positive impact. Other than antibiotics and the medications that directly affect the prostate along those lines, what other over-the-counter products can we be
So some
using?
NSAIDs like ibuprofen, and you don't have to go super strong, but you, like you said, over the counter should be just fine to help them get to some of the painful symptoms that they're experiencing.
Where does how would your approach be different, okay, with acute prostatitis versus chronic prostatitis? Any changes with chronic prostatitis? Where would you be headed to therapeutically?
We could also order some pelvic floor physical therapy with chronic prostatitis because we see that this is an issue where instead of wanting to make the muscles stronger in the pelvic floor, we actually want to relax them to help with all the tension, if you will, that may be causing some of the inflammation and spasming, contributing to the symptoms the patient's experiencing.
That's really, I have talked off camera, that's really an underutilized intervention. And over the last several years, all medical students and nurse practitioners and PAs and interns and residents who look at anatomy have been taught about a bowl within the bowl of the pelvic musculature. And we also know that there are a lot of nerves that can in that area that can be triggered by anxiety, by lower back pain, by other systemic neurologic issues, and that essentially tightens everything up. So what you're illustrating is that, yeah, prostatitis commonly has a bacterial or an infectious problem, most common E. coli, and that's why you mentioned the antibiotics we're using. But it also can be just prostate pain from chronic pelvic pain syndromes, whatever the hell that means. But that's clearly an area where antibiotics won't help. So we use other forms of intervention to relax the muscles. You said it correctly. Everyone kegels because that's what they think we're talking about. But kegels are tightening and strengthening. I don't want to do that. I want to relax. So we use a lot of entry level floor yoga that men and women of all age groups and physical abilities can use. More esoteric things. There are thoughts of Botox or PTNS, posterior tibial nerve stimulation. Think of that as what an electronic acupuncture. There are a lot of things out there. So you have done a tremendous job of illustrating just the tip of prostatitis. And
Yay.
obviously, there's a lot of information that our students at urology school need to go back and look at some of the things that some of the resources that we mentioned. All of this is a good basic skeleton of concepts and data to think about. So I thank you for that. Any other words, anything that you and I have, or you or I have missed regarding this?
I don't think so. I think we pretty much covered it. I would say, just to consider any recent history, like new partners, sexually speaking, unprotected anal sex. Those kinds of things are all important to take into consideration when doing the H&P and working up the patient.
Excellent. Great job. Very proud. Who's your professor?
I can't remember his
Dr. Bill.
name.
Dr. Bill with just the tip of urology school, working with Michelle, tackling prostatitis. Thanks, Michelle.